Poor muscle tone, weak sucking reflex, unresponsive. This is really puzzling. Nothing in her charts would indicate this.
Yeah, it's like her body isn't cooperating with her natural instincts. Do you guys think it could be a rare neuromuscular disorder?
Maybe, but her parents are really anxious, so we need to find answers fast.
Prader-Willi syndrome is a rare genetic disorder that occurs in about 1 in 30 live births. Newborns with Prader-Willi syndrome have severe hypotonia and feeding difficulties due to poor sucking reflex. By late infancy, the feeding difficulties improve. However, they eventually develop hyperphagia or excessive appetite. This continues into childhood and adulthood with addition of behavioral and mental health disturbances, intellectual disability, and hypothalamic dysfunction. Hypothalamic dysfunction leads to short stature, sex hormone deficit, sleep apnea, and osteopenia and osteoporosis, which are the main clinical findings of Prader-Willi syndrome.
So Prader-Willi syndrome involves an issue regarding and revolving imprinting on chromosome 15 of the mother chromosome. So normally a gene is imprinted on chromosome 15 of the mother, which means that the maternal copies of chromosome 15 are silenced via methylation. So there are several risks and causes of Prader-Willi, and I'm going to go over the 3 causes down below. So the first cause is if there's a deletion in the paternal or the father's Prader-Willi genes, then there won't be expression of any of them and the child will have the disease. The second cause is if there is maternal uniparental disomy 15. So essentially what happens is non-disjunction occurs in the oocyte in meiosis 1, leading to trisomy 15 once the eggs are fertilized. And what happens is if trisomy rescue occurs, then the paternal chromosome is removed and the child will only have chromosome 15s from the mother, which are both inactivated through imprinting. And finally, cause number 3, if there's an imprinting center mutation on the father, which causes it to become methylated or inactivated at the Prader-Willi region, then neither the maternal nor the paternal genes will be expressed. And for incidence and prevalence, we should all know the difference now. The incidence is 1 out of every 15,000 live births, and the prevalence rate is 350,000 to 400,000 people worldwide. You guys know, I do remember we had a genetics project back in medical school about Prader-Willi syndrome.
That's right.
That's crazy.
Yeah, that's right. Prader-Willi syndrome is characterized by poor muscle tone, weak sucking reflex, and developmental issues, but it's like super rare. 1 out of 15,000 births.
I mean, while it's rare, we can't forget that Lily has some distinct facial features like the narrow forehead, the downturned mouth, and the underdeveloped genital size could also be a clue.
Yeah, and given all the combination of symptoms and everything that she's presenting with, we definitely should do some genetic testing to see whether or not we should rule it out.
Yeah, I agree.
I agree.
I also agree, I guess.
For the clinical presentation of Prader-Willi syndrome, in infants specifically, we can often see hypotonia, which is sometimes called floppy muscles or just reduced muscle tension. They have reduced feeding and then also developmental delays in both language and motor skills. For those that are older children or adults, we see hyperphagia, which is, in other words, just insatiable hunger. And because of that, weight gain. They also have learning disabilities and behavioral dysfunction. We can also see hypogonadism in the physical exam, which is a decrease in the ability of the gonads to produce the sex hormones, such as testosterone and estrogen. And then the physical exam can also show us a small phallus or clitoris, undescended testes, and an undeveloped labia minora.
So genetic testing for Prader-Willi syndrome will include testing for abnormalities in the DNA methylation within the Prader-Willi critical region, which is the PWCR, specifically at 15q11.2 to q13. So the first tier of testing will be DNA methylation analysis and oligo SNP combination assay. And if atypical DNA methylation is found and no 15q deletion or there's a UPD 15, then second tier testing is recommended. And these second tier tests include MS-MPLA, which is methylation-specific multiplex ligation dependent probe amplification, which can reveal the approximate size of a deletion in the paternal PWCR, DNA sequence analysis, or FISH analysis, which can identify the deletion in the PWCR.
Now we're going to talk about the diagnosis, and it's usually prompted by physical symptoms, and genetic testing usually follows that when a newborn has trouble feeding or has hypotonia. There are different criteria that the patient has to meet, and for children younger than 3 years old, they must meet at least 4 of the major criteria and 1 of the minor ones, and if they're older than 3, they need to meet at least 5 of the major ones and 3 of the minor ones. And I'll give you some examples of what falls under each category. For major criteria, it could be extremely weak muscles in the body's torso, difficulty feeding, decreased growth, excessive rapid weight gain. For the minor criteria, it could include decreased movement and noticeable fatigue during infancy, behavioral problems, like color of skin, eyes, and hair.
Mrs. and Mrs. Smith, we've completed the genetic testing, and I'm afraid our suspicions have been confirmed. Lily does have Prader-Willi syndrome.
What does that mean for our baby?
While Prader-Willi syndrome is challenging, we caught it early, which is crucial. Early interventions can make a significant difference in Lily's development and in her quality of life.
Thank you for doing everything you can for our Lily. We really appreciate it.
And don't you guys worry, we'll all work together and we'll make a comprehensive treatment for your child, and we'll give them the proper physical interventions, nutritional therapy, and any education that you guys might need to help you along the way.
We're going to talk about the treatment a little bit. So there is no cure, but there is supportive care. So one of the first things patients usually need is during infancy, they have feeding difficulties. So there are special nipples or tubes available to help with that. Overeating starts around age 2 to 4, and it's recommended that parents supervise and minimize the food hoarding and prevent weight gain. They may also need growth hormone therapy later on, and because of their muscle weakness, which is a hallmark of the disease, physical therapy is recommended, and there is also usually a need for behavioral therapy and special needs programs to help in betterment of their life quality.